With a paper coming from Ukraine, from Dr. Kovalchuk, sorry for the pronunciation, I'm sure it's not correct, related with locking compression plates in type C proximal humerus fractures. Please, and we'll discuss these three papers at the end of your communication, okay? Please.
Thank you very much, dear ladies and gentlemen. Let me introduce my paper. The title is Lock-in Compression Plate Fixation of Type C Proximal Humeral Fractures. Does the type of surgical approach affect the outcome? It is a part of my PhD study made in Kiev, Ukraine. So when we ask a regular orthopedic surgeon about his favorite approach to proximal humeral fractures, for sure 90% of you will tell us that it is a standard extensile delta pectoral approach. Probably the dedicated shoulder specialist will divide 50-50 between standard delta pectoral and minimal invasive delta split approach. But most orthopedic surgeons, they just will use the standard and the classical approach, but if they will dive into the problem, they will for sure expand their arsenal, their tools available, and the more tools you have, the better surgeon you are. So, displaced type C proximal humeral fractures are associated with disturbed blood supply to the humeral head. There is no clear evidence whether minimally invasive surgical approach will provide better functional outcomes comparing to a standard one. The aim of this double-center prospective randomized control trial was to investigate whether type of surgical approach affects the functional clinical outcome of type C proximal humeral fracture fixation with the lock-in plate. In our case, it was the fillers plate. So, in our study, there were enrolled 175 patients with a mean age of 57.6 years during a 5 years period. 92 patients were randomized to a standard delta pectoral approach group, the DP group, and 83 patients to the minimal invasive anterolateral delta splitting group, the AL group. The main outcome measures were the constant score and the dash score during the follow-up visits at 6 weeks, 3 months, 6 months, 1 year, and 2 years. So this is one of the clinical examples from the AL or anterolateral group. It was a male, 88 years old, with a fracture from a simple fall. So here is our standard approach to this case. We see the upper window. We don't examine the axillary nerve like Gardner from the United States wrote about it. We just do a small approach, use a fiber wire for the tuberosities and rotator cuff, and we pull it down like a rein, you know, where you have a horse and you have a rein, and then you just palpate the nerve and slide the plate underneath. Here is the fluoroscopy, and here is the final X-ray. So, at the final 2-year follow-up, the mean constant score differed significantly between group AL and DP. In fact, it was 72.1 versus 65.4, and this difference was statistically significant. During all follow-up visits, the constant score and the dash score favored also the anterolateral group, though not always this difference was statistically significant. The final constant score values were achieved in a group AL more rapidly than in group DP, though the rehabilitation regimen was pretty much the same. Here you can see the mean constant score visits mean constant score during the follow-up visits. Here is mean range of motion at the final 2 years follow-up. It's forward flexion, abduction, external rotation, and internal rotation. The AVN, or the vascular necrosis of the humeral head, was observed in 1 patient in anterolateral group and in 8 patients in delta pectoral group during X-ray exam. You should note that we did not do an MRI, and MRI, this is one of the limitations of our study, because MRI is the most accurate method. So the rate was 0.012 versus 0.086, was statistically significant. Also, AL group characterized with significantly lower blood loss and operation time comparing to DP group. No signs of axillary nerve palsy were observed in both groups within clinical examination and postoperative electromyography. So, the conclusion. The type of surgical approach and technique in our case did significantly affect the functional outcome. Minimally invasive anterolateral deltoid splitting approach provides, in our circumstances, a more rapid return to function and superior functional outcome at the final follow-up with less avascular necrosis rate comparing to standard delta pectoral approach. Grazie per l'attenzione. Thank you for your attention. Given that the proximal humeral fractures have a great diversity and are often complex with soft tissue involvement and poor bone stock, we always have to plan your operation and operate your plan. Failing to plan is planning to fail. These words I like from Dr. Stephen Shelton, the Air Trauma Education Commission Chairman. Thank you again. Grazie per l'attenzione.
Thank you very much.